Ladies and gentlemen, welcome to the first meeting of the Health and Community Services Board. A little bit of housekeeping first. Can we please ensure that all mobile phones are turned off or put on silent? We'll start with introductions and then give apologies, and then I'd like to give a more detailed welcome and explanation to those attending. So, as introductions, my name is Deputy Richard Renner, and I am Minister of Health and Community Services, and I'm chairing this board. To my left.
Hello, my name is Caroline Landon, and I'm the Director General for Health and Community Services.
Good afternoon, my name is Helier, Deputy Helier and Assistant Minister of Health and Community Services.
Hello, my name is Rose Naylor, I'm the Chief Nurse at Health and Community Services.
Good afternoon, I'm Rob Sainsbury, I'm the Group Managing Director for Health and Community Services.
Good afternoon everybody, my name is Stephen Mayer, I'm the Finance Director for the service.
Good afternoon, I'm Emily Robbins and I'm the Chief Executive at Jersey Hospice Care.
Hello, hello, it's James Lefevre, Executive Director from Mind Jersey.
To my right.
My name is Bernard Place and I'm the Acting Board Secretary to this board.
Good afternoon, I'm Karen Pallow, Executive Assistant, and I'll be taking the minutes.
Good afternoon, my name is John McInerney, I'm the Group Medical Director for Health and Community Services.
Good afternoon, my name is Darren Skinner and I'm the HR Director for Health and Community Services.
Good afternoon, my name is Bronwyn Whitaker and I'm CEO for Family Nursing and Home Care.
Hello, my name is Adrian Noon, I'm the Medical Director for Primary Care.
Thank you, and we have apologies from...
Yes, we have apologies from Senator Steve Pallett, Deputy Jeremy Masson, Sean Ponting from the Alzheimer's Association, and Miss Ruth Brunton from Brighter Futures.
Thank you. So, again, I'd like to give everyone a warm welcome. Our state members present, members of the public, media representatives, and also to our invited partners sitting on the board. I want to say a few words about why we're establishing this board. Health and social care has to change if we're to sustain high standards of care for the islanders. And in line with the government's common strategic policy to improve islanders' well-being and mental and physical health, we must focus on preventing ill health and encouraging caring for ourselves so that more islanders can stay healthy and independent for as many of their years as possible. However, for those who do fall into ill health, we want to develop care closer to home, delivered through a greater emphasis on primary care services, facilities in the community, or care provided in our own homes. And at the same time, we recognise the need for a strong general hospital and our duty to provide excellent acute and secondary care when it's needed. So our health and care system must change and evolve. We have to find new ways of working, putting patients and users of our services at the centre of all that we do. And in Jersey, that involves not just health and community services, but also GPs and other primary care providers, charities and other third sector organisations. So how do we wish to drive that change? So overarching all our structures will be the Health and Community Services Board. That is this board, which will meet regularly. We plan to meet monthly, to be provided with assurances about the standards and the performances of the services provided by Health and Community Services. The board will hold us to account for the ambition of Health and Community Services to create a healthy island with high quality, safe, affordable care that is accessible when and where our service users need it. It will provide visible leadership, and it will, I hope, inform and create a greater understanding of the services we provide, what we're striving to achieve, and the risks that we face. I want the board to create a culture of openness and candour and instill an eagerness to learn and to improve. But how might the board develop in time? Well, initially it is a Health and Community Services Board because Health and Community Services as a State's department needs to change. And that's not least because the Controller and Auditor General told us that we weren't being good enough at being accountable and we weren't open enough to proper public scrutiny. But as this board develops and with the support of our partners, I hope that it will become the All-Ireland Health and Care Board, concerned not just with the care delivered by Health and Community Services, but all of us in a partnership that is the health and care system of the whole island. That would include primary care providers, the voluntary sector, and commercial providers. And that is why we've asked a GP representative to join the board, why we've asked representatives of family nursing and home care and Jersey Hospice Care to be members of the board, as they are very substantial providers of services. But there are also many other voluntary bodies working in the health and care sector, so we've selected as representative of them for the time being Mind Jersey, Jersey Alzheimer's Association, and Brighter Futures. Importantly, we want to invite a representative of patients and users of our services to become a member of the board also. Most important. The representatives I've mentioned will rotate each year to involve other people and other providers as the board develops. And I would just like to say a few words about what the board is not, because I don't want to create any misunderstandings. So I must emphasise it's not a statutory board, or it's not a corporate body, it's not replicating the National Health Service in the UK, it doesn't replace or dilute any of the responsibility presently held with respect to health and community services by, first of all, the States Assembly, secondly by ministers, thirdly by scrutiny panels, or fourthly by the Director General of the department. Instead, the board will be the vehicle through which I, as the Minister, and the Director General will choose to discharge our most important responsibilities and obligations. It has been established with the support of the Council of Ministers, other States members, the Controller and Auditor General, and many other bodies and individuals who have been urging us to take this step. And there is more detail available online at gov.je, Government Planning and Performance. I'd just like to run through the items on a typical board agenda, and here it might be helpful to have a look at a copy of today's agenda, which we've made available in front of you. So, standard things at the beginning: welcome, apologies, declaration of interest. Item 3 today, and we will endeavour to have this at every board meeting, a patient's story, because hearing from our patients brings their voice to the level of those running the service, those involved in the service, and will inform all that we want to do. Having that experience of the users of our services reported at the level of a board will be valuable to all of us. And the next item you'll see is a professional story. So again, we want to do that at each board meeting and hear about some new things being done within our services or new opportunities. And that might be either in the hospital or in the community, somebody from the Health and Community Services or somebody from outside that department. Then we'll have, as you'd expect in any board meeting, minutes and matters arising, and there'll be an action log which we'll go through. We'll record at each meeting what needs to be done and who is to do it, and that will be recorded and reviewed at each meeting. Then I will give a report as chair, and I would want to advise the board of the work I've been doing in the previous month since the last meeting, and how the work of government and the States Assembly interacts with health and community work. For this meeting only, I think, item 8, I will ask our board secretary to give an overview of governance structures, including new committees that will sit beneath the board. But we'll wait for that item for the detail. Item 9 again will be in every agenda. The Director General will give a report on the work she is doing. For this agenda we have as item 10 approval of the board's terms of reference. These terms of reference are not set in stone. As I've said, this is not a statutory board or anything like that. And we're beginning a journey. So those terms of reference are likely to need revision and review. And we can do that at any time, but we undertake to at least come in the next, well, in about 6 months' time, probably January, to have a comprehensive look once again at those terms of reference. Then we have as item 11 an item called New Risks Escalated to the Board, and this will be a standing item. And again, this demonstrates how we wish to bring to public attention the work of the department and how it is managing its risk and throughout the system. But the more serious risks will be escalated for discussion here, and to provide the board with an assurance that the governance around risk is functioning and the structures within the department are fulfilling their responsibilities. Then the management executive team will report on the work it is doing, again to provide the board with assurance of what its responsibilities are and how they are being discharged. Then you'll see items 13, 14, 15 and 16 are reports from new committees that sit beneath the board level with specific responsibilities for certain functions in health and community services. The board secretary in due course will say more about them, and those new committees have not yet met in their revised form, so today's reports may not be as comprehensive as they will be in the future. But we do want to initiate that process of transparency, so we will hear from the members of this board who sit on those committees. And I'm grateful to my 3 assistant ministers who have agreed to chair those committees. Then finally, or nearly finally, item 17, any other business. And item 18 is something that is not terribly common, perhaps, or a regular item on usual board agendas, but we want in public to reflect on the board meeting that has just taken place. What value it might have given us or not, as the case may be. Were the papers before the board helpful or not? Did we carry out our business comprehensively and transparently, or did we hold back? Did we miss something important? That's a quick run through of the agenda. I'm not going to do that every time. This is sort of a longish welcome to explain. In future, I won't be speaking at this length, but I just want to end by just talking about some expectations of today. And I'm very grateful for those who've come to see us perform, in a way, in a first meeting of something new in the history of Jersey's care services. It may feel rather clunky as we move through the agenda, and I'm nervous about the part I've got to play as chair, and it will probably show as we go through the meeting. But I'm confident that in time this board will mature and we as board members will become more experienced. And agenda items will start to develop more as we have the flow of information and the routes of reporting into the board embedded in our system. But it's important to start, and we will develop the work of this board. And with each succeeding meeting, we will be able to demonstrate increasing transparency around the performance of our services and how we seek assurance on the quality, safety and efficacy of those services. So I hope the board meeting will be of value to members of the public. I should just emphasise that it is a meeting in public rather than a public meeting, so that there's no opportunity to ask questions. It's a time for you to observe, and then after the event, well, you know, as politicians we must always be willing, and I certainly am willing, to answer questions and or meet with anyone at any time who has something valuable to contribute. But during the course of the board meeting, we'll ask members of the public to observe. It's like scrutiny meetings, which so many of you are familiar with. It's not a public meeting to ask questions. So it's important to start, and so to begin the meeting of the board, if we can move on to the agenda item number 3, which is the, oh yes, I'm sorry, I've missed declarations of interest. Can I ask if anybody wishes to make a declaration of interest on the board?
No.
Thank you. Okay, so we have a gentleman who's very kindly agreed to be the first of our patients to give his story, and if I may pass over to the chief nurse to introduce him.
Thank you, Chair. I'd like to introduce Mr. Steve Chapman to the HCS board today, to whom, on behalf of the board, I'd like to say thank you for giving his time today and for sharing his recent experience with us as a user of hospital services. It also gives me an opportunity to advise the board. As a department, we absolutely welcome feedback from all of those who use our services, and that we use patient stories as very powerful improvement tools. And as part of our commitment to a greater transparency in the manner in which we conduct our business in the future, we will be opening the board every time with a story from someone who's used our experience, and the voice of the patient will then become part of our business as usual. So I'll hand over to Mr. Chapman, who's going to share his story with us.
Thank you. In 2015, the end of 2015, I was diagnosed, well, I had coughed up some blood. I went to my GP, he sent me for an x-ray and blood tests. The results came back negative, nothing wrong with me, heart and lungs double. A couple of weeks later, into 2016, I had the same thing again. I repeated coughing up more blood. I went back to see my GP again, who sent me to EAU. At the time, when there was a gentleman who studied the x-rays again and the blood tests, came out and told me that nothing wrong with me, nothing on the x-rays was showing up. I was informed that it was more than likely a polyp in my throat. Then a house doctor came and seen, well, my wife and my daughter was there. They came on and told me there would be a CT scan. It's on a Wednesday, sorry. On the Friday I was told that there would be a CT scan ready for me to go to on the Friday. I phoned up the surgeon's secretary on the Thursday because I didn't have no time. I was told I was talking rubbish. There was no such way I would get a CT scan within 2 days. So eventually I did get a date a couple of weeks later to go for a CT scan. I went for the CT scan on the Friday. I got a letter the following Friday to say that they had the results and will I go in the following Friday. There was no mention of anything being untoward. I never got a telephone call or anything to say that there was anything wrong. When I went in to see the specialist, the first words he said to me is, why haven't I brought a family member with me? So I thought, well, the alarm bells are ringing now. And then he informed me that I had lung cancer. It was hard to see on the 2 x-rays previously because it was behind the heart. So I was having a chat to him. I asked him about the prognosis. He said to me, more than likely there would not be anything they could do because the tumour was so close to the aorta, it was only 1 millimetre away from the aorta. I said, so what do I do? And he went to me, was a bit shocked at the time, and I thought I had a long tell wife and kids. In the meantime, the only person I could speak to was an appointments clerk. He was the only person who was in the room with me. At the time, there was no designated respiratory nurse in the hospital. I had to obviously go away and tell the wife. The surgeon I spoke to actually wrote to Southampton then to speak to Mr. Chamberlain from Southampton, who I had a meeting with a couple of weeks later, to say that he'd done this operation every day of the week and there was nothing to worry about. So I've been sitting for 3 weeks thinking I was terminally ill. In the meantime, I'm involved with one of the Jersey charities, and we went and got funding for a respiratory nurse, so which was one of the good points, who was paid for 3 years. Her work has been invaluable. There's people who I would have been able to go and speak to. Obviously, she wasn't there at the time. She's done booklets and paperwork and everything, which wasn't available at the time. I got a sheet of A4, which told me, and it was photocopied, which told me for about a PET scan what I needed to do. And it went on and on and on. Eventually, I went to Southampton, had the lung removed, came back, and went under the oncology department, which has been absolutely phenomenal. I've told my story, which obviously I can only tell in a couple of minutes, but it goes longer and longer. And now, obviously, I've just been going for treatment and chemo for the last 3 years, but the chemo department and the oncology department is phenomenal. And that's, I'd like to elaborate on it, but I know we haven't got the time. So.
Unfortunately, we can't give a lot of time to these items, but I've said to you that if you want to come and meet me at any time, I'd be happy to discuss things with you. Mr. Chapman, have you had a response from Health and Community Services staff to the sort of concerns you raised?
To Helen O'Shea at the time when Helen was in charge. I went out in a meeting with her. She didn't believe half the points that we spoke about. Then, after she resigned, I spoke to Rob, who was fantastic. He took the story on board, and with Rose, it's been ongoing ever since. It's great to know that the hospital now is interested in more than what went on a couple of years ago.
Okay, I'm pleased to hear that. Do any other board members have questions? Yes, Director General.
I'm sorry that the care that we delivered for you is not the care that we aspire to deliver for our patients, and thank you for coming today, because it's a really powerful story. Could I ask the Group Medical Director, has that story been shared with our clinicians, and if so, what is the learning that has come from it and the actions that have resulted?
Yeah, I mean, I think we need to listen to patients, and certainly we need to do better when they raise concerns. I think civility is very important, and I understand that patients don't always have the same insights we do as to what is available. I think the work that we're going to do to introduce a patient advisory liaison service as well should be very helpful to patients, so that we can meet patients much sooner. So rather than a series of emails or letters, actually speak to people, islanders, and actually find out what their concerns are, and then speak to teams, because as Chief Nurse says, I mean, this is a valuable learning for all our teams. It's actually how to be better clinicians and actually better advocates for our patients.
Yeah, the part that came back when the respiratory nurse, and that she's taken on now, I believe she's been taken on, the funding from the charity finishes after 3 years, and she's going to be full-time on the hospital board. She was invaluable because now she speaks to patients who I never had the chance to go to. As I say, when I was told, I had an appointments clerk in the room with me. And when I left there, I was convinced that my numbers was up. But as you say, it is getting better and better. And
So I'd like to hear about that better and better. I'm struck by the passivity in the relationship, which we would not want to have in any service delivery model in health and community services, where you should own your care and drive that care, regardless of who's in front of you. How has that communication improved? Is it tangible now? Do you feel that you're empowered to make collaborative decisions with your clinicians?
Yeah, the staff who are involved now, where before there was, they had specialist nurses for all different types of cancer, breast cancer, brain cancer, prostate, but there was nothing for one of the biggest killers, which is lung cancer and the respiratory. But now, with that nurse being here, it's invaluable. She's phenomenal. And the paperwork, let's say, that we had was given to us was a sheet of A4 paper, and all it had was PET scan, tick. CT scan, tick. Blood test, tick. But at least now there's a final booklet that she's produced, and it's great. And you find all the things that they do with the charities as well, as in West Macmillan and Jersey Cancer Relief, and they're all involved as with this board, and it will be outstanding when it comes out.
Thank you, Chair.
Yes, sir.
Chair, if I may, just to reassure the Director General, the story has been shared with the wider clinical fraternity. Mr Chapman kindly came to our Integrated Services Committee. Some of those clinicians who'd been involved, or their team had been involved, to hear the messages directly. And as the Chief Nurse says, this is really driving the improvement needed. There were three real themes that we drew out. The first was around the communication and the difficult conversations and ensuring that the patients are supported in that. But there is something really significant around the ongoing support thereafter, and the role highlighted around the specialist nursing role isn't a unique situation just in relation to this condition, and we have a number of other support roles that have been funded through charitable mechanisms that we need to devise a plan for how we ensure business continuity going forward, because they're not formally part of our plans at this stage. And I think this is highlighting an example that we need to give attention to how we make sure this is brought into normal service delivery.
And how are we assured going forwards that when we have to have difficult and challenging conversations with patients about their prognosis, that those conversations are happening appropriately and that staff have been appropriately trained to do that?
Yes, we need to do more training with our senior staff particularly, but this is where the role of the PAL service that the medical director highlights, I think will really come into fruition, because they'll be providing a lot of support and a lot of direct support to patients in that scenario. But we have to set up more training and education for those staff. And the group medical director, through the leadership of the associate medical directors, I think will be pivotal in driving that, as well as the chief nurse.
And the committee structure, because I'm sat here not fully assured that if you had to present again, that the conversation would be more meaningful. What committee structure is that work plan going through to provide assurance to this board?
That would be the Quality and Performance Committee.
Thank you, Chair.
One of the letdowns was being informed that you had cancer. I mean, no one wants to hear that word. And at the time, how do you tell people? This was one of the things I met with Rob. And how do you tell people you've got cancer in an easy way? And there is no easy way. Some people you can say, yeah, I can, no problem. I know he'll take it on the chin, no issue. But another person, frail person, won't be the same. And it all goes down to the person and the specialist who is seeing that person at the time. The biggest shock for me was the wife had been with me to every single test, and I said to her, look, obviously there's nothing wrong. I said, because we would have known in the letter. And that was, the first way through the door was, why have you brought a family member? Not, oh, we've got a bit of an issue, or a phone call or a letter to say, look, we found something, and can you come and meet us? But to walk through the door and be told that straight away, man, that was the shocker to me. But since then, so look.
No, sorry, I was just pointing to Dr. Minahan, who was sitting.
Yes, thank you. Can I ask what arrangements have we got in place to assess what specialist support that we need to have? So, Mr. Chapman has spoken about the absence at the time of a specialist respiratory nurse. How are we assessing what specialist support we need to have and getting that in place?
So, if I may share, myself and the Group Medical Director and the Chief Nurse have been developing our target operating model. One of the key deficits we've had relates specifically to cancer strategy for the island, and we've established a clinical support service and cancer care group going forward in our new structure. The head of that care group, which is a doctor, is devising how we develop our cancer strategy, and as part of that will include the workforce plan, and that will pick up specialist roles that are needed for now and the future, looking at our demographic changes and our growing disease prevalence, and they will develop the plans working with us to start to bring into fruition how we manage these kind of needs that we have in the island.
Good, pleased to hear that. Are there any? Yes, CEO.
Could I just ask,
Yeah.
do you feel you had the opportunity to go back? I mean, obviously that news was quite shocking for you and you were on your own. Did you feel you had the opportunity to go back and discuss that? Because sometimes people need more, they need to
Not with
synthesise that information.
Not with the specialist I see. No.
And do you think that's changed now?
Yeah, I know, I've known staff in the hospital for a long, long time. And yeah, there's certain people who you could have chatted to without energy. But the way I was told by this, obviously I'm not going to say your names, but it was wrong the way I was told. And I know I wouldn't go back and see the same person again.
And are we assured that that wouldn't happen again and there are people to talk to on a second or third time?
That's between us now is, if you have any issues, you can speak to her. She's great.
But I'm with you, Bronwyn, it's about consistency across service delivery and ensuring that we can try as hard as we can to ensure that no other patient has the experience that you have.
Yeah, in the last few years, I have seen an improvement. Yeah, for what, so I know what Rob and the board are doing is definitely improving.
Any other questions? Yes, CEO.
Just perhaps an observation that as part of this review process, we look at how we could signpost patients better.
Yeah, we must make a note of that and be aware of all that in our planning.
It's never easy to tell someone, and it's never ever going to be easy to tell someone. And I've never envied the job of the person who has to go to training. But there may be.
But we recognise we could have done that far better, and I'm sorry
Yeah,
for
with me,
what we went through.
I think it has moved on since then. Hopefully.
So we wish you well for your continuing care and recovery, and thank you so much for coming to speak to us.
You're welcome. Thank you.
And then we move on to the next item, item 4, which is our professionals story, and I will ask our Group Medical Director to introduce.
Thank you, Chair. It gives me great pleasure to introduce Dr. Adrian Noon, who today is going to give us an update around the valuable work that the shelter is doing on a day-to-day basis and how Health and Community Services is trying to support that valuable effort too.
Thank you, Chair. As part of the target operating model, which is being implemented through health, which is a change in how health works, the heads of these groups are going to be clinical, they're going to be doctors. So we are starting to meet in a very embryonic form at the moment, but at one of our first meetings back in March of this year, I was meeting from a primary care perspective, and I met the Associate Medical Director for Acute Care and the Associate Medical Director for Psychiatry, at which it became apparent that there was a common challenge really facing all three of us. From my point of view, I was looking at the people who attended at the ED department most frequently, and we looked at the 20 most frequent attenders, and we were trying to put in some sort of a plan to help them so that they didn't need to attend the ED department so regularly. At the same time, my psychiatry associate medical director colleague was also looking at his most frequent, did not attend outpatient appointments, and we found that the list of names was very, very similar. So we began to dig a little bit deeper into this and look at this group of patients, and came to the realisation that these were actually some of the most vulnerable patients on the island that often lived in the shelter or were homeless, had a very chaotic lifestyle, could often couldn't afford to attend a primary care consultation or felt embarrassed about it, or had found that they'd come into arrears, or most importantly were part of what we call our vulnerable adults programme, which is patients who've exhibited violence to general practitioners, hospital doctors, other healthcare professionals, and so need to be managed through a separate scheme. So we went round to talk to the shelter, who were very open and very, very supportive of a situation where we have a very small number agreed of very vulnerable patients who can't access healthcare in a substantive way for all sorts of reasons. So we launched a plan to try and take that healthcare to the patient and actually put it in the shelter. So we have progressed over since March of this year to now have in place, planned for September, a GP funded through the Vulnerable Patient Scheme, who will provide 2 sessions a week of primary care in the shelter, a consultant psychiatrist who will go in and do 2 sessions a week in there, a full-time healthcare assistant and sessions from family nursing to support them, 2 sessions of CPN work, psychiatric nurse work, and a 4-session-a-week alcohol and drug support team, a social worker who's going to go in there weekly, and a podiatrist monthly, and our smoking cessation team are going to go and do some work in the shelter as well. That's happened in the period of 3 months. The building is hopefully going to start next week, and we're converting an area in the shelter into 2 clinical rooms where these patients can receive high quality care from different parts of health to hopefully improve their outcomes and their quality of life. That's probably the first time I've ever come across that in my career in medicine, where from very disparate parts of an organisation a common objective has been reached. Thank you, Chair.
Thank you.
Questions.
Thank you, Doctor. Are there any questions about that initiative? Yes.
Not a question, Chair, but it's just to highlight to the public that one of our care groups is not headed up by a doctor, and it's headed up by a chief social worker, which is our social care groups. And all of the others are headed up by doctors as part of the new target operating model.
Thank you.
Chair, could I
Yes, Chief.
question? So thank you, Dr. Noon, for the feedback. You said at the beginning that this initiative came out of looking at the number of most frequent attenders using the emergency department, and I wondered, by introducing this, what sort of feedback you've had from those people in terms of accessing a different facility. What's their experience been like?
Yeah. So we spent quite a lot of time talking to the patients in the shelter about what their needs are. Often it's a crisis, and if it's a crisis that needs an emergency attendance in the emergency department, that's absolutely the most appropriate thing. But quite often it's a combination of chronic problems that have built up over a period of time, and they very often felt embarrassed to go to the emergency department. They felt that it could be better managed by a regular review by clinicians of different specialties actually in the shelter. So we're hopeful that we can measure that now in terms of attendances in the department and attendance with psychiatric teams over the next 6 months, and see if there's an improvement there.
I think it's a fantastic new way of working for people that's taken them outside of their normal care setting to provide care somewhere else on the island to meet the needs of a group of people. So I just want to say well done for doing it in such a short space of time.
Thank you.
Any other questions or comments? No, equally I'd like to say it's good to hear that we're looking after vulnerable people who might otherwise not attend at the A&E and fall off our radar until there's an emergency. So that's a great initiative, it seems to me.
Thank you, Chair.
I should beforehand have just welcomed Dr. Nigel Minihane, who's come in. And
apologies, the day job took over.
And I can quite understand how busy you are, Dr. Minihane. You're here representing the GP body, and thank you for taking part in the board. The next item on our agenda is the minutes of the previous meeting, but of course this being our first, there are no minutes. We would then normally move on to the next item, matters arising in action log. I don't know, Board Secretary, would you say something about those?
Yes, just very briefly, there will be a record, a minute of this meeting taken by my colleague Karen. But what I will do is focus on the actions that we agree through this board and create an action log where nothing will be falling off the table. But I will chase those actions, will make sure they're delivered to the standard this board expects, and I will see that as a not just a pleasure, but something that will give me huge satisfaction to help keep moving this agenda on its. That's the focus, action.
Thank you. Yes, just action, but documented action, so that we will know what decisions have been taken, what needs to be done, and monitor the doing of it. Next, item 7 is a report from me. I'm going to be briefer than I was previously. This is intended just to be a report on what I have been involved in since the last meeting, and essentially much of my work has been around 2 things. The work involved in establishing this board, recognising that it's vital and important part of my duty now to create good governance and oversight from top to bottom of the organisation, or as some people are saying, from board to ward, which I rather like. A large part of my time has also been taken up in the government plan, which will be lodged in about 10 days or so. And this is a programme for government for the next 4 years, including our revenue raising and the expenditure we want to make. And we are planning 2020 in detail, but also putting some plans and some figures around the subsequent 3 years, and then revising that each year to put the flesh on the bones. But there's a lot of work going on, a lot of negotiation between ministers and departments, because there's only a finite resource in terms of taxpayers' money, of course. How do we best spend that, and what is most effective in terms of the services government wants to provide? I've also been asked to sit on the new Our Hospital Political Oversight Group, which has met once or twice so far. Once, I think. No, twice, sorry. So that work on planning for a new hospital is commencing, and I'm looking forward particularly to assessing the care model that the island wishes to adopt in the future. But that's a whole other subject, but I'm just reporting to say that I'm on that political oversight group. I was particularly pleased to be involved in the organ donation campaign and presenting legislation to the states which identified the National Organ Donor Register as the place where we can sign up to be organ donors if we choose, and indeed, importantly, to decline to be organ donors if that is our wish. I thank all those who worked on the campaign, and I urge everyone to have the conversation, as the campaign slogan is, about whether or not we would wish to donate our organs if we were ever in those circumstances. And I continue to be conscious of all the change that is happening in health and community services. A challenging time, and particularly around our target operating model, which is now reaching our final stages. And I'd like to record thanks to all the staff within the department who've borne with us through uncertain times and are continuing to deliver great care, and I acknowledge their contribution. And I'm open to any questions, please. No? Well, that's fine. Thank you. Can I move on to the board secretaries, who will give us some information about our governance structures?
Yes, in your packs you will have what's called an organogram that describes the corporate governance structures. There is a glossary of terms, and I'm conscious we use a lot of language in these boards, and one of those terms is corporate governance. And corporate governance is simply concerned with the structures, systems and processes by which the Health and Community Services Department leads, directs, controls its functions in order to achieve what it wants to achieve. And so my role as board secretary is to support the establishment of this board and its committees, so it's able to provide assurance in the way that the chair described. And assurance simply is a way of providing evidence and certainty to the board that what it intends to be happening is indeed happening. It helps us to answer a key question. Do we really know what we think we know, and how do we do that? And we do that through a whole series of means, which I won't describe in detail, but they're reports, dashboards, progress against action plans, a whole range of documents which themselves have been assured and approved. So we have an overarching board, which is what you see today. It's the oversight body for health and community services. It's supported by a number of committees. And there's something very special about the way we're doing this in Jersey, which is not like anywhere else. Our committees are chaired by assistant ministers, and just as this committee is chaired by the minister. Executives attend, they provide assurance. Senior clinicians will be involved and engaged in those committees where that's appropriate. And that what we have to do is, as this board matures, is establish that line of sight that the chair described through the care group structures which are being established, so that we have a way of connecting what we talk about now to the experience of patients and those we care for. So the committees we have established are the Quality and Performance Committee, that enables the board to achieve assurance that high standards of care are being provided. And we have in that an assistant minister as chair, and we have the chief nurse as the lead executive. We have a Finance and Modernization Committee. Finance, obviously, about the money. Modernization, particularly about the importance of information technology that's so critical to our future delivery of services. And that's chaired by our lead finance director, Stephen Mayer, but also then chaired by an assistant minister, Deputy Raymond. We have a risk committee, and that's to assist the board in the oversight of risk management and the effectiveness of what's called internal control, how we manage these risks to make sure that we manage them to a residual level which is acceptable, or how we avoid them in the first place, how we keep control of those risks, because healthcare is intrinsically a risky business to be in. So we have to control those. That committee, the lead executive is our Group Medical Director, Professor McInerney, and the chair of that is Senator Pallett. We have a People and Organisational Development Committee to assure the board that our people and organisational function is able to deliver its strategic objectives. And workforce redesign is critical to making sure that we have a workforce which is fit for the future. That's chaired, the lead executive is our lead for HR, Darren Skinner, and Deputy Masson is the chair of that committee. We also have a Management Executive Committee, and the purpose of this is to serve as a senior decision-making group beneath the board, assisting the Director General, who is the accountable officer for all of this, in achieving the strategies, aims and objectives of health and community services. And so that's the overarching corporate governance structure which I will support, establish and develop in the coming months. And as you say, we're at an early stage, we're on a journey, it's work in progress, but we need to make rapid progress to be able to provide the assurance to members of the public and our staff that we are on track.
Indeed, thank you, Bert. Are there any questions or comments on anything the Board Secretary has presented to us? No, okay, thank you. I can move on to the Director General's report.
Thank you, Chair. So I will take the paper as read, as it has already been circulated to board colleagues, and just do a few highlights. Echoing what the Minister has said, thanks to our staff who have been engaged in what has been quite an onerous process around the target operating model. The end is in sight. Referencing what Dr. Noon has said about our movement to a clinically led organisation, I think that is endemic in the documentation you our governance structure. And as Bernard has alluded to, we are on a journey. Absolute recognition around the challenges we have with our mental health estate, and that has played a primary role in our submission for our government plan, which the Minister has advocated very strongly for us. The governance framework, which Bernard has alluded to, which we are working on, and our Finance Director will be talking to us about our cost improvement programme and the efforts that we are making to ensure that we spend the Jersey Health Plan sufficiently as we can. A very exciting opportunity to be engaged in the new care model, and I'm sure that will arise in conversations with executive colleagues as they talk about their community structures. And finally, I'm 3 months in post and very grateful to be here as Director General, and really pleased to be around this table today with colleagues. Thank you, Chair.
Thank you. Any questions of the Director General or concerning her report? No questions? Okay, thank you, Director General. Then the next item is the approval of the Board's terms of reference, which is the document grandly entitled Schedule of Decisions referred to the Board and the Scheme of Delegation. Board Secretary, would you like to say something about
Well,
this document?
before you talk through that, I think it's important that we have to establish the committees to do the work of the committees, and it is the Board that establishes that by saying in the schedule of delegation what work they want those committees to do on the Board's behalf. So that's really the structure of the document, and it reflects conversations and within the executive team and the Board itself.
Thank you. Yeah, I propose just to ask for comments page by page, but first of all, does any Board member have any general observations they'd want to make?
Can I just ask, Chair, because
Yes.
it's quite a comprehensive document, and we are just embarking on this journey. When will be the review date for this scheme of delegation? Are we doing 6 months or are we doing 12 months?
Yes, we're doing 6 months in the first year,
Right.
and then we'll do that annually thereafter. So I would hope to bring some feedback on these terms of reference to the December or the January committee, but we'll review again the following July.
And can I just clarify that the scheme of delegation around finances is because that hasn't been decided centrally?
The issue is the reorganisation, Director General, where colleagues are going through that. That'll change, therefore we thought it more appropriate to bring the new scheme of delegation once it's been through the Finance and Modernisation Committee, rather than the old one, which will change once the restructure finishes.
And will that be interrogated by Assistant Minister?
Yes.
Okay, thank you. Thank you, Chair.
So this surrounds a treasury function, is it? What delegation is given to departments in terms of their spending?
Yes.
Understood. If we can take the document and just run through page by page. So page 2 is simply the contents. If there are any questions, please raise your hand or shout. Page 3. Anything? Page 4. There are only 9 pages. Page 5.
Chair, if I
Yes.
may, I just wonder, I'm not sure whether it's page 4 or 5 or which committee, but there are other committees or board structures that we have that are quite significant in our strategic planning, and the Director General highlighted the mental health agenda as one specific. And so the Mental Health Improvement Board, which reports through to Quality and Performance Committee, as well as MEX, whether or not we need to specifically mention that. And I'm wondering whether or not Safeguarding Partnership Board also needs to have a direct link that you can see in terms of this document and our governance.
Do board members agree that would be advisable to do?
I think particularly, I know if I was external to HCS, if I look on page 6, number 14, for external partners to receive assurance around effective whistleblowing arrangements, then we absolutely need that linkage through, don't we? But we also need that clear information through the In20 performance report.
Yes.
Is that the
find a method of ensuring that appropriate committees can have a view of the work being done
Yes.
in the committees that sort of sit partly within HCS and partly without?
Yes, the way I would propose that is to do an organogram so that each committee understood what it should be receiving, which group it should be receiving assurances from. The Mental Health Improvement Board is one such important committee that we need to have an organogram coming through quality and performance. Now I can sketch that out. I think the important thing is to establish the committees first, and then for each committee to be assured that there's a line of sight to wherever our patients are being cared for, even if they are not areas that we formally manage. So a good illustration of that is the ambulance service. The ambulance service, we have patients who arrive on our front door, but we don't manage the ambulance service anymore, but we are important stakeholders in that. And I've been in touch with those leads already, so that's what I'll map out for this group.
And CAMS would be another area.
CAMS, again, we met on Friday with the key people who are going to take that service forward. We are absolutely clear that we need a line of governance, a line of sight from those services and the children they care for and we care for, that this board can be assured about what we have delegated to them.
Yes. Can I just ask the group medical director if that would fit in with the plans around CAMS at the moment and the governance structures that are envisaged?
Yes, so as the board secretary said, we met for the first time on Friday, and it's not just CAMS, it's the children's development services as well,
Of
so
course.
it's all community paediatric services. So we are making sure that we have a line of sight, that we have governance, and this needs to go through the Q&P committee, so that we can maintain clinical governance, information governance, and corporate governance links across those care groups.
Yes, thank you. Director General.
Can I just ask can't see anything, but I may be missing it, around F&M committee, around our commissioning arrangements and ensuring we have probity, best practice and value for money around that. I can see that there's some statements around outcomes, but not where we're going to be monitoring our commissioning contract.
We're going to bring a paper to the next meeting of the Finance and Modernisation Committee, which will precisely pick up that point and bring it forward for the board to consider.
And then if the board approves that, will that be a regular part of the finance report so that colleagues are able to participate in that decision making?
Yes, it will be.
So that will be detailed. Will that be amendment to these terms
Yes.
to these terms of reference? Thank you, Chair.
So can we bring that forward to note that we need to revise part of our terms of reference to better include that commissioning overview? Any other comments around pages 5 or 6 or 7 dealing with the committees? Page 8 we go on to the People and Organisational Development Committee.
Again, Chair, I would suggest, and in line with our previous board meeting in private, that if I could ask the HR director, because it feels that we can't just discuss people and organisational development in isolation, though recognising this is embryonic. So what are the plans in place to link into island-wide discussions around resource? Are they there?
No, not at present, but we're going to be working on that as part of that piece of work.
So is there going to be some reference to that as admittedly an aspiration, but within the terms of reference, just conscious that we're not operating in isolation in HCS?
No, they're not captured in the terms of reference, but that's something we will amend, subject to our conversation.
Will that go through POD?
Yes.
Okay, thank you, Chair.
Can I also ask in follow-up to that, to the HR director, does there need to be something in here specifically in relation to the HCS relationship to the State's Employment Board as well,
Yes.
given this relates to...
Valuable.
Yes, they will need to be because they are the employer.
Yes.
And again, sorry.
Can I just take a question from the CEO?
As part of that, could I request that terms of reference are drawn up to specify
to involve our third sector partners at the right times, so that they have early insight into what is planned. Director General?
No, I was wrong. I can see it in point 4. I was going to challenge our FD around equality and diversity. I see that Quad have that already covered. Thank you, Chair.
HR Director, is there any other point you want to make? So generally, on our terms of reference, any remaining questions or comments? Dr. Minihan.
May I ask how this board relates to the wider political circuit in terms of money flow? One Gov, as Mr. Parker has put forward, particularly looking at how money would follow the patient, very conscious that primary care is largely financed by the what was the Social Security Department, CLS now. So how does this board relate to other boards, and how will money flow? So particularly thinking with a new hospital, if the new hospital is of a smaller size than one might have expected perhaps a year or two ago, how will that money be channelled into the appropriate new care model, and how will you work with partners outside of this HCS board?
So, well, as I see it, the funding of the new hospital and its mechanisms, that's yet to be worked through. So I don't think there's any certainty or detailed planning around that as yet. This begins really as a health and community services board to manage the budget that's allocated to health and community services. But we may develop ways of working with other structures. I hope we would. And I've spoken already about our wish that this board develops into a more inclusive, all-island board that delivers or has oversight of the entire health and social care in the island, if that is the way it chooses to evolve.
But thinking particularly of the social determinants of health, which we've all alluded to in terms of the very vulnerable, but we have a group of people in Jersey, what one might describe middle Jersey, that we've identified, who don't have the resources to necessarily seek primary care at the moment, and I think that's a very important component of what this board should be addressing going forward.
It is important. Work is going on. Perhaps I can ask Director General to comment on any further work.
Thank you, Chair. So, as my colleague is aware, we have a piece of work happening at the moment around health and community services and the wider health economy to create a proposal for our new healthcare model, which you are involved with around primary care. Absolutely, we are supportive, and I will ask executive colleagues, perhaps our medical director, to elaborate around money following the patient, money following activity. And I think as an organisation we are moving very firmly towards a model where care is not centred in the building in Gloucester Street, but actually is far more devolved out and closer to home. And I know that the medical director is particularly keen in his work stream around primary care to address that troubled middle who do not access primary care. Could I ask you to elaborate, please?
I was going to interject, Chair, as well. So yes, so the work we're doing that we just started is the future care model, which actually is a symbiosis of 3 separate streams: secondary care with mental health, primary care, which is not just GPs, it's optometrists, pharmacists, nursing. It's also another stream which is our partners in charity and the third sector. It's about using all those components, which is very unique to Jersey, to come up with a care model that's affordable and sustainable, and something that we can actually interrelate with our future hospital as well. So yes, that work is just starting. As one of the people that's been invited to those workshops, obviously the opinions of GPs are very important, but we do need to be mindful that this is a very delicate balance between the third sector, HCS, primary care, but also customer and local services as well, which is another partner, and Department of Finance. So all these players are going to have to get together and work for this future care model, which we'll be doing over the summer.
Thank you. And is that work being reported to any of the committees we are establishing?
So thank you, Chair. At the moment, it's very much our 3 work streams, which we are working with partners and colleagues within HCS to plan what that would look like for the future. The first committee that will go to, which actually isn't a committee, is the POG at the end of September.
Yes.
So at the moment it's not sat within our committee structure because it's a work plan that sits outside that. If it gets approved by POG, then it will come through our governance structure.
That's the political oversight group of the Our Hospital
Yes.
project, isn't it?
Yes. But, you know, I mean, I think my GP colleague has very much raised something that was raised similarly by the CEO from Family Nursing, which is we recognise that we cannot act as a board in isolation and that we have to link in island-wide to deliver care. And that is our hope and aspiration, and that by inviting colleagues to join the board that we will start to be able to share governance structures and opportunities and move to a more collaborative model of island-wide health.
Does that help you, Dr. Mindy? Thank you. Are there any other questions around the terms of reference of the board? So can we resolve to approve the terms of reference pending review in 6 months' time? Is that appropriate?
Yes, and subject to the approval at the committees as well. They will look at their part in more detail.
I understand, yes. Subject to that.
So sorry, Chair, could I suggest, because I think there's been points raised by multiple board members, that we make the amendments and we circulate prior to sign off? The colleagues find it to ensure that colleagues have sight around those changes?
I think that's very important because there will be changes coming out of the government plan. I'm just looking across with what you were saying, and especially with what Nigel was saying. There will be movements. There has to be because, as the DG said, the money is not there for the new hospital at the moment. So over the next 14 days, there will be changes. I don't think there's any doubt. And the other thing is we have to stress, putting my political hat on, not necessarily is everything going to get through.
Well, we will.
We'll fight everything.
The government planning process is ongoing. Our objective is to lodge within the next 10 days, and as far as I know, that's still on course. We will see. Still meetings to be held, aren't there, Hugh?
Yes, sir.
Yes, so that's how we must bring to the next meeting a revised terms of reference to reflect what we've discussed today, and also any comments the committees have, of course, and refinements they wish to make. Thank you. The next item 11 on the agenda is called New Risks Escalated to the Board. Actually, before we start, I should just say, you know, our discussion over the last 15 minutes perhaps has may to some have seemed rather dry. It's all about boards and terms of reference and that, but I am convinced, and I can see how this is a vital part of delivering health and social care in the island. We've got to have a rigour about our organisation that makes sure that we don't miss things and things don't just fall by the wayside because there hasn't been a proper oversight of them. So it does sound very managerial and everything is going through boards and committees and the like, but it is the only way and it is the proper way to ensure that everything is picked up, that risks are assessed and managed, and that at all appropriate levels there is good oversight of what the department is doing, and hopefully as we evolve what everyone is doing within health and social care. So perhaps you'll forgive us for so much managerial talk, but it's I think in time you will see the value of it all. But and one of those is that our risk assessment and management, which will be throughout the organisation, at lower levels, they'll be dealing with certain risks, escalating them if they go to a level that they cannot manage, to a point where serious risks need to be brought to this board. And then perhaps I can ask our Chief Medical Director, our Group Medical Director, sorry, to talk about this item, new risks escalated to the board.
Thank you, Chair. So the agenda item 11 has been circulated, so I'll take it as read. I'll also give some key points. An escalating risk is one that was identified by the Comptroller General's report, recommendation 22, that we should establish robust arrangements for the preparation, maintenance, review and challenge of risk registers relating to health and social care, including rates for escalation. So our response has been to feedback that we wanted to produce a board assurance framework, but in lieu of the fact we did not have a board until today, that has been delayed. As the executive lead for risk and for the risk committee, the work is going to be ongoing over the next month to produce a board assurance framework document, which I intend to bring back at the September board with an update and thereafter complete by October. I think it's very important we have that board assurance framework document so that we can tie in all the aspects we've just been discussing.
Yes, indeed. Any questions about that board assurance framework or the paper presented to us? Director General? Yes.
So the workshop on the 29th of July, Medical Director, who's that at?
So that'll be across the care group heads.
Lovely.
And because I think that the fact again, wall to wall, we need to make sure that this comes from the ground upwards, but it's signed off by the board.
And when does it come to board? When do those strategic objectives come to board to be signed off?
September the 30th, which I think is the next board meeting, is to give an update on what it says in the paper.
And is there going to be a board workshop in addition to that to discuss those strategic objectives?
There is, yet to be arranged.
Okay.
Yes, that's the intention.
Any other questions? Right, well, we wish you well as you develop that work and look forward to seeing it again in the September meeting. Item 12, can I pass over to the Director General to give a report of the Management Executive Committee?
So, as I shared with colleagues in Part B, there has not been a meeting as yet of the MEX. That first meeting is scheduled to take place later this month. That meeting will be quite a large meeting of probably about 30 people, so it's going to be lots of decision making going on there. And the intention of that meeting is that business that traditionally in the past has gone across the Director General's desk will go across the desk of MEX, which will be a membership of our care group tribes. So that's lead nurse, lead doctor, lead manager, and also a lead AHP. And that's it really. I haven't got much more to say until we have the next committee, but hope to be able to bring a lot more stuff back to the next board.
So just to clarify for members of the public present, we have 8 care groups. Is that the case across the service?
10.
Oh, it's 10, sorry, yes. I beg your pardon, I should know that, shouldn't I? And they will each have, as you said, their executively, their tries, meaning a triumvirate. Okay. And it's for that reason that there's those 30 people you mentioned contributing to this management executive. So this is, I see this as a good example of asking clinicians to play their part, well, and all professionals, because it's not just those working in clinical services, in the management of our department.
Absolutely, it's a replication of our executive tri, which is our medical director, our chief nurse and our managing director, who operationally manage the organisation. We replicate that down through our care groups so that we are able to affect clinical leadership. Again, it's embryonic and it's a new model for us in HCS, but I think the consensus is, particularly from our clinicians, that it's a safer way for us to deliver the business of care.
Has the Controller and Auditor General reported on our structures around the care groups and has she passed comment? Or
yeah, she has taken a very positive view to the fact that we are moving to clinical leadership, not just not ostensible clinical leadership, but actual clinical leadership, whereby we are devolving budgetary responsibility and decision making down to our trials.
Thank you, Director General. Any questions arising? Okay, so we move on to item 13, which is the first of the new committees, the Quality and Performance Committee. And if I can pass over to the Chief Nurse to give her report.
Yes, thank you, Chair. Just to start with, there's 2 reports included in the paperwork, and I'll take them as both read. In relation to the first report, 13A, this really sets out the key items we discussed on our previous assurance committee, which was quality and safety, which was the committee that we had for assurance around patient care prior to our new governance arrangements coming in. So this really reflects the last meeting of that committee. This is now moving under the new arrangements to a committee which assures quality alongside performance, which need to be considered in our permanent model moving forward with equal attention from an assurance perspective and a patient experience perspective. And when I've given a brief update, I'm going to hand over to our group medical director, our group managing director, to provide an update on where we're up to around developing our performance framework for the future of the HCS board. So a couple of points I just wanted to bring to the HCS board's attention today is really in relation to our assurance framework that we have around the areas in which our care is delivered in our inpatient wards. So we introduced a Jersey Nursing Assessment and Accreditation framework about 18 months ago, which is run out through my office. And what's involved in that framework is that wards are assessed against 14 care standards, and these standards are set out alongside the same standards they would use in the Care Quality Commission. So we are measuring wards through observation, through talking to patients, through looking at patient records, and from interviewing relatives and observing staff against a number of standards, looking at things like safeguarding, pain management, patient safety, nutrition and hydration, environmental safety. So that's just an example, but there's 14 standards in total. So that gives us a real clear line of sight, and myself as chief nurse, really good oversight in relation to practice that's occurring on our inpatient areas. The standards are then, the wards then get an assessment report on the same day that they are visited. We do the assessments now on an unannounced basis, so the team will turn up on any given day without the wards necessarily being pre-warned and undertake the assessment. What I will say is, whilst that gives us a really good line of sight, we discussed it at the last Quality and Safety Committee in relation to the physical environment, which we know does present a challenge from a nursing care perspective, and that really relates to the lack of storage facilities, how wards are able to maintain their corridors clutter-free, and I have to say our staff do a really good job, and we do have assurance around that, but the physical environment does present a challenge. We'll continue with the Jersey Nursing Assessment Accreditation Framework, which is called JNAS for short, and we've also undertaken that with one of our provider organisations. So Jersey Hospice Care have also been assessed on 2 occasions to date, and we hope to expand that broader across the care system. The other thing I'd like to bring to the board's attention today is our diabetic retinal screening. And this was a matter of concern for the committee, and I'd just like to ask our medical director to give us an update on the improvement work we're doing in that area.
Thank you, Chief Nurse. So, Chair, this issue first materialised last year. Diabetic retinopathy screen for those with diabetes. We put in a mitigation plan, prioritisation of those most at risk, and those have all been imaged. We've hired a clinical manager for the service to work with a partner in the UK so that we can improve our service so it's a robust, well-governed service that treats all those with diabetes, that are children, women that are pregnant with diabetes, and all diabetics into the future. So I hope to produce a formal report next week for Quality and Performance Assurance Committee, which could then be fed back to the
please do.
I'm just going to hand over to the Group Managing Director who's going to give us an update on the performance element of the quality and performance committee.
Thank you, Chief Nurse. A key part of the Quality and Performance Committee will be a review of our performance standards that we're developing across the department. It reflects the new arrangement for care groups, so each care group will have standards set for it. As the board would expect, there will be a key focus around access to our service, what our patients can expect in terms of waiting times and how we are progressing against our waiting times and key pressures. It will also focus on how efficient our services are, from theatre utilisation, the way our outpatient services work, how long patients can expect to be within our inpatient services. Beyond the hospital, there will be key metrics identified for social care, which is having a particular focus, and of course mental health is also going to have a high level of focus, and we're developing a new performance framework for that area and that care group as well, which reflects our improvement plan. Beyond our department, we're also working with partners in how we develop a more whole systems metric that we can understand how our services are working together, what continuity in care our patients are getting, whether they're coming in and out of our services too often, and how we can join that up. So there will be our services provided in terms of our own performance, but we're looking to develop a whole system performance metric that also comes through to this board, so we can all review it going forward. Take any questions?
Any questions for either of those people who've spoken? Seems to me it just emphasises how important data is to be able to measure the quality of what we're doing. Would the CEO of Jersey Hospice wish to comment on the JNAS assessment which you've taken part in?
Thank you, Chair. We've been very pleased to take part in it, and very pleased with the growth and development that has been demonstrated by the staff who've gone through the process. And very much welcomed that as a team. So their enthusiasm for it has matched that of the senior management within the organisation.
Excellent, thank you.
Chair, could I just make a few points out of the second report that's been provided, if that's okay?
Please do so.
So the second report, which is 13B, sets out really the sort of direction of travel in relation to quality and performance in relation to how our new assurance committee is going to work moving forward, and really talks to a number of the changes that we're making as part of the target operating model. And I think particularly pertinent for this meeting is the really strengthening the patient voice in our improvement journey moving forward. And part of the work around that we're doing at the moment is developing an accountable framework for the new care groups. So that's work that will really set out how the governance arrangements in the care groups going to work, and that will include all of the things that we will be assured at in relation to our quality and performance committee. So that work's underway at the moment, and it's detailed in this report. Happy to take any questions.
Any questions? No?
Just a comment that I know there's been a lot of work put into this by both the chief nurse and the medical director, indeed the TRI, and I think what this really starts to do is give us that absolute assurance that the care that we're delivering for our patients is safe, and that we start to have that visibility across care delivery. So it's really valuable to see. I think going forward it'd be really useful to start to see those metrics around how we deliver care, and so that we can start to understand the impact that some of our changes are having.
Of course, and mental health being such an important priority at the moment, there's a care group established around mental health, so we will be receiving their metrics, and the Mental Health Improvement Board will be reporting into the Quality and Performance Committee. So we will be able to have an oversight in that respect. CEO, yes?
Chair, just a point to note, we will also have some other information coming out from, of course, those organisations that are going to be care regulated, which will also help us with performance and quality, so there'll be quite a lot of information coming out over the next year and so on, when the first quality checks and through care regulation, so there'll be some learning from that can come to the board as well.
Yes, thank you for that. Of course, that's highly important. As a separate development, the Care Commission is in full operation now and is has already commissioned a report into Children's Service, and will be commissioning further reports and registering and inspecting service providers. So thank you for that reminder.
And I think it's that transparency that is key, and it will be really good to start to see that system transparency. But for us, particularly in HCS, knowing that if we have an issue at ward level with hand hygiene, if we have an issue with falls, and if we have an issue with pressure ulcers or infection, that actually those issues are transparent through our committee structures and get escalated to board, so that we as board members have oversight around those inhibitors in delivering care.
Indeed. Any other comments or questions around quality and performance? Then if we can move on to the Finance and Modernisation report. Finance Director.
Thank you. The first paper just gives an outline of the scale of the department's budget, which as you can see is 200 million revenue and 11 million capital programme. Both budgets are under control. The department regularly reviews them, and it anticipates at the year end it will be in balance. Inevitably, in an organisation of this size and complexity, there are variations as you go through the year. Finance colleagues work with colleagues across the service, and we report those up through the Director General, through MEX and other elements. It is intended to bring forward to future boards a budget monitoring report, an update on the efficiency programme, touching on our review of budgets, consumables, contracts that we operate, as my colleague has referenced, also things such as theatre productivity, among other matters, so that the board can receive assurance about the financial soundness of its operations, it can track changes, and it can challenge variations as it so chooses to do. Thank you, Chair.
Any questions for the Finance Director? Deputy Raymond, as chair of this committee.
The candidacy bits always come to the end, don't they? Can I say that there has never been a Finance and Modernisation Committee before, and we're not doing anything different that you wouldn't do with a limited company or a private company, and that is that with Stephen, it's been very great over the last couple of weeks. We've been looking at what it costs to run a hospital, and I think that from my perspective it's quite a sort of eye-opening operation, because I think one tends to forget they still have to pay electricity, they still have to do things. And if you look at the overall budget, which is 201 million, isn't it? So, we were lucky last year because if you look at the notes, we had a surplus which we were allowed to keep, and we also had some money from the States. We're getting very close to the end of the year, so hopefully with all the hard work that the Finance Director is doing, we should be able to hopefully keep going and come up with all the things that the DG has wanted to do with with Richard. But what I want to say is this business, as you know, I don't like the phrase, but I'm the political lead on the hospital. And that is representing, dare I say, politicians. Where we are at the moment, there is a lot, and I will say this, I mean a lot of work going on behind the scenes. The trouble is, with the target operating model and everything going on at the moment, we're being sort of sidelined, but there is a particular politician in here as well today who is very much party to one of the other schemes that is part of the hospital. We will not use this committee to talk about the hospital for the present time. We'll only use this committee in agreement with everybody to talk about the hospital as it formulates. Because as you know, we've got a fairly stiff time. What is it, February 2021. But we will keep everybody informed, and of course with the people on the committee as well with me, we can keep everybody abreast of the situation. It's going to be tight, but we're going to see if we can have a go. But the main thing is, with this committee, which is the great thing, it gives us also another forum and, let's say, another transparency that we can get out there to the general public. And the most important thing on this hospital, nobody wants to see it fail, even the people that talk about it. Let's make the hospital work, let's get it going. And that's what we hope to do for this committee and other committees that are being put into process. Thank you.
Thank you, Deputy. Entirely agree. Are there any questions around either of these reports on finance and modernisation? Director General?
So, FD, we've had conversations about the Minister and I wanting to bring to this board monthly delivery, forecast outturn for the year, so that board members can start to have sight of how HES is spending its money and actually have visual proof that we are on track to deliver our outturn position.
Yeah.
When is that likely to happen? I know it has to fit into the timetable around the states. But is that in progress for us to be able to have that transparent statement of cost and spend?
Yes, we have such a document, as you described, Director General. I believe it is going through the Council of Ministers in approximately 3 or 4 days' time, so we'll be able to bring that to subsequent meetings of the committee. We are simply making sure the diaries fit together, and it's already in preparation.
So the omission today is down to the timing of the board? So going forward, we'll have monthly position, annual position?
Yes.
Thank you.
Again, an example of how we wish this board to demonstrate transparency in all that happens within the department. Right, then, no more questions on this item. Can we move on to people and organisational development? And if I could ask our HR Director to speak to his report.
Thank you, Chair. So I'll take the report as read. This also formulates the statement of intent of the work that needs to be undertaken by this new committee. As you can see, it's quite an ambitious agenda. A lot of the work that has been set out for the coming months and years hasn't been undertaken previously. So there's a phenomenal amount of work to be done, particularly around developing a workforce or people strategy. Workforce planning, which is absolutely vital to the healthcare system on the island, and following this the earlier meeting, we're going to expand that to be working with our partner organisations, given the impact that such a big department can have on our partner organisations in terms of workforce. We're also looking at education, learning and development, because it's very important to grow our own on the island, but also it's a very good recruitment and retention tool and medium. We're also doing a lot of work around health and wellbeing. A phenomenal amount of work has been undertaken already around training our staff in mental health first aiders, mental health awareness training, trauma and risk management, as well as resilience, particularly with a workforce that's going through a phenomenal amount of change as part of our target operating model at the moment. We're doing a lot of work with our medical staffing department and our doctors around job planning and revalidation, again driving through some performance with our medical colleagues. And probably most importantly, our HR metrics, which we have a small absence of data at the moment due to the change into a new system, but I'm assured that we'll get far more data hopefully towards the end of August this year. We're doing a lot of work around quality and inclusion. It's work that hasn't been undertaken previously, and we have quite a large agenda in that area, particularly around not only for our staff, but also our patients and service users. And we're doing an awful lot of work around key worker accommodation, not just for healthcare, but across all difficult to recruit to positions across the island in order to assist in recruitment and retention of our staff.
Thank you, HR Director. That equality and inclusion programme, is that across the whole of the states?
No, this will be specific to health and community services. However, I'll be working with our newly appointed Director of People Services, particularly because this has an agenda of interest to him.
Okay, I understand. So I'm sure they could learn from us. When will that be fully in place?
That will be a huge piece of work and ongoing. As I said, the first committee is next week. So what we hope to do as part of that committee is to start mapping out what our priorities will be and what
moment. And I wondered what assurance we have as a board around the people going into new leadership roles in relation to the support for their development in that new way of working. Will that come through your board?
So yes, as part of the target operating model implementation, we are looking at a leadership development programme, particularly for our new leaders, newly appointed associate medical directors, because a managerial role is quite new for them, for those posts. So we're looking at a leadership development programme for them, not just for them, but for also for the people that will be working closely with them, the lead nurses, the lead AHP and their business managers, as well as their HR and finance business partners.
Thank you, Chair. I know it's very close to the Minister's heart about equality of access to healthcare regardless of presentation. That work you're doing around that equality of access, is that linked in with the work that the Medical Director is leading around the new care model?
It will be, and we'll, as part of the committee, the Medical Director sits on the committee, so he'll be fundamentally part of that work.
And is that on the agenda for the strategic aims and objectives workshop?
Yes, we've got a meeting just this week with partners around looking at those islands that have difficult access in our services, be that due to financial reasons or due to illness. It's like Dr. Minhag says, there's Middle Jersey that's also we need to consider. But yes, so that's going to be identifying those groups that should be brought into the umbrella, whether it's due to unemployment, housing, long-term illness, end of life, and hopefully identifying how we can actually try and bring them into the safety net.
I just have a question around the capacity, really. If we are bringing people into leadership roles within the care groups, then are we able to replace them in patient-facing services and the care we're offering, or is there any strain there around our services for lack of capacity?
Initially, I think it's going to be quite difficult, but as we build that capacity through the work that we'll be doing in terms of the leadership development, hopefully we'll develop that capacity. Certainly for the associate medical directors, they get specific protected time for that development of they're called SPAs.
But will it be impacting on our patient care, basically, if these people have extra responsibilities?
No, ultimately it will improve our patient care.
So yeah, so we've been very mindful not to asset strip the clinical facing aspects of our services. So in some instances we've had to go out to recruit, backfill, be innovative. But yes, that we were quite cognizant that this could be an issue, so we've actually identified that ahead of the recruitment.
And are we achieving what we want to achieve?
I believe so, yes.
Is that the case? Good. Good. So any other questions around the People and Organisational Development Committee? Then we move on to the Risk Committee, and I ask the Group Medical Director to give his report.
Thank you, Chair. So I'll take the agenda items as read. I'm just going to give a brief synopsis and also give the assurance report for Steve Pallet, who's obviously giving his apologies. So as you mentioned earlier, Chair, I mean, health and care is a risky business, and it's the same throughout the world that I've worked, but also there's a Jersey context that we need to be mindful of. So the Risk Committee's job is to identify risks, put in controls to mitigate that risk, and then review what's happened. So part of that is to have a corporate risk register, which we need to get on and complete. To give you an idea of what risks are current, they'll be the same anywhere, it'll be around staffing, our estates, financial. It could be future risks such as Brexit. Sarah mentioned the B word today. So we've got our first meeting next week on Monday. It's a newly constituted assurance committee. It used to be the Risk and Oversight Committee. We have got, as I alluded to earlier, we've got the board assurance framework document to complete. But to give you some ideas, some key risks that we're facing in health community services across the island currently, We need to address gaps in our service to mental health clients, which I think has been well publicised, and certainly we've managed to recruit into key roles, both in medical, nursing and other roles within the service, and we've asked for some financing into the next year's government plan. We also are very aware that the estate needs replacing. Again, we have some capital allocations we've asked for in the next government plan. There's also risks to the current hospital, that it's ageing, that it's got facilities that need to be updated. We need to maintain safety and quality to all our patient groups. So again, we have to be aware of risks that might be current or in future happen in the hospital estate. And there's other things such as risks of moving services, like we're moving CAMS, as we talked about, and children's development services into SIPs. We're moving ambulance services into justice and home affairs, and we need to make sure that those risks are controlled and mitigated. And I'm assured that we can do that. So just to give you a final assurance, looking in the absence of a board assurance framework, I can assure you that there is no current breaches of any statutory or regulatory compliance, but obviously we need to get a board assurance framework document up and running as soon as possible to be absolutely assured of that. Chair.
Yes, understood. Questions or comments on the report?
Chair.
Yes.
Just about the estates infrastructure, I'm assuming you're talking about the wider estates as well. This is one health economy, so there will need to be investment in infrastructure in estates if we're going to change the model of care. So is that alluded to in this document?
Yes.
Or somewhere else?
When I use the words estate, obviously the hospital is very topical. You can also talk about a digital estate, you can talk about other forms of estate. So, and also housing across the island, we need to look at that. So it's multifactorial, but yes, when I use that term, I didn't mean to just focus on hospital.
Good question.
Medical Director, so on your report when you say a number of divisional risks are scoring more than 15 but don't appear on the corporate risk register, I'm just aware that I and the Chief Nurse reviewed a risk register this week which was scoring risks as 15, but actually when we challenged that risk and looked at the mitigation, they were significantly less than that score. How assured are you that that is real, and how, when were those risks last assessed and scored?
You're quite right. I mean, I think any risk register is a dynamic state. It will change month to month. I'm not sure, we obviously have the Risk and Oversight Committee. We've also got some external assistant looking at our risk register. So at the last Risk and Oversight Committee, I know that the risk register was discussed, but I do think we need to have an overhaul of the actual risk register and actually have assurance at the board level that every month that we are absolutely certain where we sit in terms of the rating. It's actually good to be, I suspect that as we are risk averse, people tend to overestimate a risk, and there's a danger in that too, because that can upset and worry the public, our staff, but we do need to make sure this is a regular, and I think the care groups, it has to be disseminated again, so every month the care groups themselves have their risk register reviewed, so they can bring up any new risks, and that's that whole board to wall again.
So when are those risks, because as accountable officer, I'm concerned if we have risks at 15 that are deemed catastrophic, that they have not been reviewed. So when is that piece of work going to be completed, so that we have assurance for this board that we are not carrying those risks?
As I say, Chair and Joe, we're meeting certainly I'll be leading this for the first time on Monday, so I shall give you assurance thereof.
Okay.
Chair, can we also advise the clinical risk are coming to the Quality and Performance Committee as well on Monday, so there will be oversight from two assurance committees.
Okay, and from the cursory look that we did of the risk register, is the assertion actually that those risks would be estate risks, not clinical risks?
We've done some additional work with our support that's come in relation to the risk registers, so we do have clinical risks on there at the moment that we'll be discussing at Q&P on Monday.
Okay. And those risks will come through to board
Yes.
if they are significant risks
Yeah,
of mitigation?
Yeah.
Okay, thank you, Chair.
Thank you. Can I ask the Group Medical Director, is there a standard methodology that we use for the assessment of risk?
Yeah, so there are international benchmarks that you use for risk identification, but as I said, there are some that are unique to Jersey.
Yes.
We live on a fantastically sunny island. We're quite remote from our tertiary care centres, so that's a risk. There's sometimes fog. We have a major incident aspect that we need to mitigate as well, that we look at a mutual aid plan. So yes, so there are international benchmarks, but at the same time we need to make sure it's bespoke for our local population and services too.
And how do we train those people involved in the assessment of risk?
That's a very good question, a very difficult one to answer. It's like education, education, education. It's about constant looking at other jurisdictions to see how they manage risk and train our staff. And again, it's part of the leadership function for our heads of care groups, which are not all doctors, some are other clinicians, some are social workers. We need to make sure we include that in our training scheme.
And I think, Chair, that the work that Rose is doing with the external governance support around an accountable care framework is also feeding into. I don't know if Chief Nurse wanted to elaborate more on that work.
So the accountable care framework, which will really shape what governance arrangements will look like, that will have to be delivered much closer to the patient than perhaps we've done in the past. So this will include all aspects of clinical governance, including the management of their risk register. So through the reporting arrangements that our board secretary advised on before, those care groups will be expected to manage and mitigate and treat those risks. Anything that they can't manage that scores above 16 will come up through to the management executive, which is the meeting that the Director General will chair across that big group. Again, we'll discuss, review and challenge those risks. Anything above that we are unable to manage or mitigate will go up to the next level and ultimately up to the board. So we are significantly strengthening our risk management process.
Yes, that's good to hear. Right, there is no other business notified prior to the meeting, so what remains is a reflection by board members on our meeting today, which, as I said before, is something new and perhaps unusual to us, but it will be helpful, I think, to just reflect whilst it's all fresh in our mind. And if I can begin, gosh, I found it difficult hard to, what am I trying to say? I'm sure, yes. Difficult to work out where we are and who needs to say, but I'll no doubt get used to that. But I'm encouraged to see the candour that's been brought to the meeting, that last discussion we had around risk, for example. It's important to put that forward, to explain the health service carries risk. We're not servicing machines, we're looking after human beings who are all different and there are risks. How we've got to manage those, we've got to accept that perhaps in the past we've not been as good as managing that risk as we should be. But I'm encouraged to see that there are processes in place which mean that as this board develops, we will see us getting better at those processes. I thank everyone for their contribution. I think we'll free up as we have further meetings. We'll be able to engage in good ways with each other and challenge each other and explain the work we're doing. But okay, over to others now. So, Director General, your thoughts?
It's really valuable to sit around the table with colleagues and partners from other organisations and to start to receive some assurance, very early days, around the work that we're delivering for our patients. But most valuable for me today was you, sir. Thank you for coming along and hearing your voice, because it is the voice of the patient that we want to hear much more louder in HCS. And the whole point of our structures is that clinicians and patients working hand in hand to design our services. So thank you.
I can't say much more than that, DG. I think it was great to. Can I be absolutely political? It would be lovely, actually, not to go bananas, but just to receive a couple of emails from the people like you, just saying, what did you think? Because here we are sitting around the table, and it's interesting to hear what you think. You can't say anything now, and we accept that, but it would be quite interesting to see what you think. Whatever it is, you know, waste of time, heard it all before, all that sort of thing, but it would be great to just hear what you thought about it, and if this is the right way going forward. I think being able to work with everybody, and everybody knows what they're doing, is with regards to finance, and the fundamental thing, which is what the DG says and the head nurse, is what we're dealing with, people. And that's what we've got to look after.
Okay. I'd just like to echo my thanks to Steve, who has not only given his time today, but he's also given time in preparation for coming today. And, you know, as a clinical professional myself, we always try to do our best, and sometimes we think we know what's best. And actually, it's only when you hear back from people who've used services, you realise it's something completely different and we're a bit wide of the mark. So the more we can get that into our business as usual and have that as more of the norm, the better. And just to say thanks again.
Echo the thanks. I thought it was a really good first board. Probably needs to look at the practicalities of the layout. Good, we can see each other. Maybe think about a V shape or something a bit different so that it's easier to interact with colleagues down the table. But,
Yes.
I'm sure we'll develop that.
I think it represents a very good start, Chair. I'm sure we can improve. I'm sure we can bring better and more transparent information in the future as well.
CEO?
Thank you, Chair. I think it's been a very good first meeting. As a representative of the third sector, I'm absolutely delighted to see government literally sitting around the same table. We've talked for many years about co-design, more collaboration, partnership, lots of words like that banded around. This really feels like a step in the right direction.
I'd absolutely echo that as well. Really good to hear mental health spoken about in an open way, with clarity for all the other important things there are. I regret having asked for the aircon. We couldn't hear ourselves before the aircon, but maybe it's just today, but it has felt quite uncomfortable all this.
Yeah. Yeah. We'll try and find somewhere that meets our needs. Board Secretary?
So people may be aware that we've been filming this. It's important to know that our aspiration is that we'll eventually be able to use this film to share our work with people who are not able to attend the board. We're going to use the first couple of board meetings really to learn from these films as to how we're discussing the kind of things we've discussed today, a level of challenge, clarity of questioning, all of that stuff to help us on this journey that we know we've got a long way to go, but I think we've made a good start.
Thank you, yes.
I like the professional story about the Shelter Trust. I thought it was a very good example of multi-agency working.
Thank you, Karen. Director?
You know, I certainly feel very humbled to be part of such a fantastic island. It's the first time I've sat in such a big group of people in an open board. Obviously, the always going is to help people, but it's nice to see people helping each other across different specialties, across different organisations. It'd be nice to see a patient or a user on the board as well in the future. So thanks.
HR Director?
Very much echo what my colleagues have already said, but also the work that I do across the department tends to be quite insular, and I'm really looking forward to working with our partner organisations and the third sector and some of the work that we do, because I think we can make a real difference across the island.
Good. CEO, Family Nursing?
I think we've got an opportunity to make a real tangible difference, and I'd like to thank you for coming in, because I think it's a really hard thing to sit and talk about and talk to a group of people on board. I hope we make a difference to all of you.
Dr. Noon?
No, echo particularly. I mean, it's our health, isn't it? It's for everybody. All of us in here are going to be patients at some point. So it's great to have a team of people who are willing to work together and not always get it right, but actually being able to sit here and say, actually, we've got that bit wrong. What do we need to do to make it right? I mean, that's a huge step forward for this island.
And Dr. Helier?
Well, apologies once again, excuse you for missing your story. It looks like I might have the last word, which is very unusual.
Well, we won't allow that to happen.
I want to change it. It's encouraging, very encouraging. General practice particularly is often felt out on a limb, and we've talked, to echo what was said over there, about this for many, many years, so it's very encouraging that we're all working together and hopefully looking at this as one health system.
Yes.
And if we can achieve that, then we'll have moved on with you.
Yes. Okay, well that brings our board meeting to an end, except to say that our next meeting is on the 30th of September at 3 p.m. At present it's set to happen here, but if that's to change, that will be notified. I thank everyone for attending as board members, but also members of the public and media and state members for coming to watch us at our first meeting. Hope it's been of some value to you, and thank you very much indeed.
Now you have ended your board, can I just say you haven't issued any instructions